So essentially, we've spent the last 2 days talking about the United States, and now we're going to cover the world in about an hour. That was partly by design, unfortunately. The idea here of this session was actually to be able to learn from experiences abroad, both in the developing world and the developed world. I think we're going to learn more about the developing world in this panel discussion today, but we could perhaps take some other comments afterwards or questions about the developed world. So I'd like to start off by introducing our speaker, Elizabeth McClure, research scientist at Research Triangle Institute. Welcome.
Thank you very much. And as Russ mentioned, we are today on the panel mostly going to talk about low and middle income countries. We're not going to try to address all international research. But again, joining me today will be Joel Segre, who's representing the Bill and Melinda Gates Foundation, Eve Lackritz with the Global Alliance for Preventing Preterm Birth and Stillbirth, as well as Robert Goldenberg, who's an obstetrician at Columbia University and also a principal investigator with me on the effort I'm going to be describing today. So what I do is I work also with the NICHD-funded Global Network for Research for Women's and Children's Health. And one of the major initiatives we've undertaken in the last, actually since starting in 2006, 2007, was this trial on antenatal corticosteroids, which we used ACT for the antenatal corticosteroids trial. So just very briefly as background, which many of you probably have seen before, the rates of preterm birth are very high, and especially high in sub-Saharan Africa and Southeast Asia compared to many other parts of the world. Similarly, when we look at the etiology of newborn mortality in low and middle income countries, you can see that prematurity represents about 1/3 of all neonatal deaths, more than 1 million every year, and more than half of all neonatal deaths are preterm. And 98% of these deaths occur, as we all know, in low and middle income countries. But I think, as Russ points out, the majority of the resources do go right now to high-income countries. So it's great today to have a little bit of time to talk about the efforts in low and middle income countries, because I think many of the things we've talked about over the last several days, you'll see we have similar challenges, but an order of magnitude larger in implementing these efforts in low and middle income areas. So just briefly, we've already talked about the benefits of antenatal corticosteroids, and this was part of the impetus to undertake this trial. As we thought this is a relatively low-cost intervention that's been shown to be efficacious in high-income country settings, very well documented, and it seemed like a good intervention to undertake in these settings. And you can see the rates of use of antenatal corticosteroids, as we've talked about at this meeting, in the US and other high-income settings, it's 80% and higher, whereas in countries in Latin America, studies have shown only 30% or less of women receive antenatal corticosteroids who need them. And when you get down to low and middle income countries, it's maybe 5, up some places up to 10% of women who need steroids who actually receive them. So that's the question. Why is an intervention that's proven to be effective, safe, relatively easy to administer, and inexpensive in most high-income countries still underused in the low and middle-income country settings? And again, some of the barriers we've talked about over the last couple days are very similar to what we found in low-income countries. But in addition, there's just simply a lack of availability of the drug. There's lack of guidelines, even on, again, a magnitude above what we see here. There's many different local regulations about who can receive or administer injections, and these are in settings where most women are delivering with community birth attendants or with no birth attendant. Similar, there are factors related to health providers, policymakers, including just lack of awareness or familiarity with corticosteroids. Again, there's some concerns by providers about founded or unfounded about administration. And then a huge issue is the ability to determine accurate gestational age. And again, same problems we talked about here, but on an order of magnitude larger in low-income settings. And finally, related to women themselves, there's, again, lack of knowledge or awareness about signs of preterm birth, as well as the lack of accessibility related to the Utah stories about no transport to get to the hospital or get to a provider for appropriate care. So the trial was really undertaken for a number of reasons, but one is to see, was the effect of antenatal corticosteroids in low middle-income country settings similar for women who maybe come to antenatal care in a clinic but then end up delivering at home? So are these outcomes similar when you use steroids as when you use them in hospitals where women have access to newborn intensive cares services? And then also just the safety issue. Is it safe to administer steroids in these settings? So again, we undertook this trial to look at, can we increase the use of steroids in areas where there's almost no use of steroids currently, looking at the impact on mortality, newborn mortality associated with steroid use, and also look at severe infection as a potential safety measure. And again, because we don't have very precise gestational age dating, for us the primary outcome was powered on what we called small babies, or babies that were the less than 5th percentile birth weight for their country. Just briefly, the methods, the steroids trial was conducted by the NICHD-funded Global Network, which is a multi-country research network that was established in 2001, in part by funding from the Gates Foundation as well as NICHD. The study was undertaken in 6 countries, Argentina, Guatemala, 2 sites in India, Kenya, Pakistan, and Zambia. And this was a cluster randomized trial, so we had 102 health regions, and we looked at a population-based sample. So within those regions, all deliveries were included, those that delivered at home, health centers, and hospitals. And we had an independent prospective registry that collected the outcomes in those settings. And this is, again, just to graphically illustrate where our sites are located, and in parentheses shows you how many clusters in each of those sites were included in the trial. So again, just briefly, the registry is a really important concept because we've had this ongoing registry for now 5 or 6 years, where we have very good tracking of women who are enrolled during pregnancy as early as possible, but generally by 20 weeks gestation. And then we follow them through 6 weeks postpartum. And then, again, just to emphasize that for the trial, the registry staff are independent of the women who are in the ACT intervention or implementing the activities for the trial. So the main parts of this intervention were, 1, to improve identification of pregnancies at risk of high-term birth, and then secondly, to provide and facilitate the use of antenatal corticosteroids. Again, most of these settings did not have steroids available as routine care at most of the levels of services. And this just gives you a graphic of, we had these posters in health clinics and health centers for women and providers. Again, many of the providers and women are illiterate or very low skill level, so we have signs of preterm birth. And then to help with gestational age dating, we had a gestational age wheel with the red indicating refer and a fundal height tape, refer. And then we had this preterm birth kit, which included instructions on how to use the corticosteroids as well as the steroids themselves. And for this trial, we used the dexamethasone for reasons that Dr. Wapner talked about this morning. It's much more inexpensive, and also stability in settings where you don't have a cold chain. And then also just the approval process. All the countries we worked in already had dexamethasone, whereas betamethasone wasn't readily available at most sites. But the idea was, even in the community settings, we would provide awareness, but the idea was ultimately to refer a woman to a provider or a hospital who could give her the services she needed at that point. And this is just to show you the process. We used a sort of cascade model using the train the trainer. We did central training with our investigators in Washington initially, and then a team of us went to each of the study sites and trained the doctors, physicians in that were running the study, and then those went out to each of the intervention clusters and then trained all the birth attendants, nurses, midwives, et cetera, who were conducting births in those areas. And this is just to give you a little sense of the population that is in our study. Overall, the population represented across all our sites was over 1 million in estimated annual births. And just to say, these are the intervention clusters. So we had annual births in the intervention clusters of about 32,000. We had 175 different health facilities that were involved with the intervention activities, which included 13 hospitals, which were tertiary centers, and 162 lower level district hospitals or health centers. We had over 1,000 facility birth attendants in the trial, nearly 200 physicians, 600 nurses, and then a number of other types of health workers. And then a number of community health providers were also involved in the trial efforts. And this is just to give you a sense of our study sites. With the exception of Argentina, where almost all women deliver in the hospital, most of our sites, like Guatemala, had 40% hospital births. Zambia has about 10%, Kenya, same, and then Pakistan also about a little over 20%. India's, I think many of you know India rates of hospital deliveries are getting higher, and it's close to 70% now at our sites. And then again, looking at the types of birth attendants, physicians, represented on the left, were highest in Argentina, but for most of our other sites, in Guatemala, 60% of the births are delivered by community birth attendants, which are basically unskilled local birth attendants. Zambia, also 40%, Kenya, 50%. And then one other sort of indicator of quality, you can see for cesarean section rates, Argentina has 35% C-section rate, but then our other sites, especially the African sites, are less than 5%, and India is about 15% now. So unfortunately, I am unable to give you any trial results today, but just to say that we just completed enrollment with over 100,000 women in the trial overall, and our data analysis are underway as we speak. We're having an investigator meeting at the end of this month, and we're really hoping to do very rapid publication, in part for some of the reasons that Joel will be talking in a moment. We really feel like this is an important trial to inform the public health field. So I just want some graphics of our group, and to really thank, I'm speaking on behalf of a large group of investigators who've worked on this for, like I said, since 2006. Many of the people that were mentioned in this meeting today, Alan Jobes, our chair, Robert Goldenberg, Wally Carlo, have done much of the research in the past on corticosteroids. And then really the PIs of this study are Fernando Altabe, Jose Belazan from Argentina, together with Pierre Buekens from Tulane University. But these are our global network sites. So we have a partnership with a site institution in country with a US-based institution which has the NIH grant. So anyhow, thank you all very much for your time, and I will turn it over to Joel. Thanks.
Hey guys, super fun to be here. I'm setting aside my Gates Foundation hat for a moment and putting on my UN Commission for Life-Saving Commodities hat. UN Commission for Life-Saving Commodities is a group of organizations from around the world coming together under a UN umbrella to advance the use of, you guessed it, life-saving commodities. In the case of antenatal corticosteroids, we brought together magic. Open sesame, yes. We brought together a group of more than 20 different relevant member organizations, all of which are interested specifically in advancing antenatal corticosteroids around the world. And you'll see that there are a whole bunch of implementers and advocates in there. There are a bunch of research organizations. Several of the folks who Beth just mentioned, who are PIs on the ACT trial, are involved. And then, of course, there are donors sort of backing this and doing our best to make it happen. In general, we essentially are trying to do, the general theory of change is we want to take a look at the evidence and listen to caregivers to understand what the barriers are to antenatal corticosteroid usage around the world, and then proceed with essentially 2 action plans. One is sort of at the global level, let's figure out what we can do that's going to help out all countries. And then at the local level or at the national level, try to identify the specific barriers in certain places and create essentially those reference case hospitals that can show their neighbors, perhaps within the country or in neighboring countries, that, hey, this is actually possible. We can increase antenatal corticosteroid usage. Now, when we say we want to increase steroid usage, we essentially have 3 guiding principles related to that. The first one is to focus on dexamethasone rather than betamethasone. Now, it's for the reasons that Dr. Wapner and Beth actually just mentioned in terms of a 100x reduction in cost. In other words, betamethasone in the formulation you want, which is the acetate and the phosphate, is 100x more expensive than dexamethasone. But the other issue is that betamethasone is often easily confused in the developing world, where they will not necessarily differentiate between betamethasone phosphate, which is readily available in pharmacies, and the Celestone concoction of betamethasone phosphate plus acetate. So when you ask someone, well, which betamethasone are you using? They hold up the vial and say, this one, betamethasone, right? And there's that sort of nuance isn't there. And that's partly difficult in a country like India, where Celestone is actually not legal for sale because it is above the mandated price cap of what betamethasone should cost. So you have this scenario where you're like, wow, let's keep it simple. Let's work just with dexamethasone. The second guiding principle is to start only in district hospitals, in high volume facilities. And that makes sense because we avoid the issues of traditional birth attendants who may or may not be able to diagnose or may or may not be able to inject, and all sorts of policy issues related to that. So we want to start at the highest centers, and hopefully we demonstrate great care there and it trickles down. And we don't do this as a vertical program. We do this as essentially a gateway drug to broader quality improvement. So we show essentially in some district hospitals that that you can in fact increase your dexamethasone usage, and at the same time you are using a quality improvement process to do a holistic improvement of management of preterm labor. So we try not to do that alone. And then the third thing we try to do is to try to bias toward action. And this is the one that might be a little bit more controversial, and I hope that it'll still come up in the discussion as well. But the quote from one of our members, Fernando Altabe, was essentially, if you think of it, give it. So if it occurs to you, you're probably doing okay. Which is not saying give it to everyone, but rather saying, if you have sort of incomplete data about exactly what's going on in this case, there should be a general bias toward action. So with that, at the global level, we've done a few different things here. The first one is to essentially increase the awareness of antenatal steroids within sort of the global organizations. So 2 years ago, if you were to get on Google and type within the UNICEF or the World Bank search engines prematurity, you'd get a couple of hits. And if you were to type in antenatal steroids, you would get 0 hits. That's changed now. And antenatal steroids are really sort of part of that discussion. The second thing that we've done is to add dexamethasone, which was already on the essential medicines list, but to add it for fetal indications, which we successfully did in 2013. So now it is listed for this particular indication, which we view as a good step forward. The third thing has been to develop a web portal with critical documentation on antenatal steroids. So when you go to this website, which is on Healthy Newborn Network, what you'll find is a collection of all of the relevant evidence you would want to see, some country-specific analysis, and then there will be actual videos and sort of case testimonials. In this case, it's of a nurse in Malawi who has begun using steroids within her hospital and giving essentially anecdotes of what the challenges have been for her, what the effects are that she's seen, and so on. A little bit of a softer side to it than the Roberts and Dalziel Cochrane review of how this stuff works in high-income countries. The next thing that we've done has been to initiate a guideline revision from the WHO. So previously, the WHO guidelines was from the MCPC, which is over 10 years old. There was a little bit of conflicting data this way and that way, even within the MCPC. And in November of 2014, we will see a new set of guidelines coming out that will that will hopefully standardize and endorse the use of dexamethasone for fetal indications, although that guideline is yet to be published. Then the last thing that we've done has been to develop somewhat of a standardized training materials that can be used sort of in the way that Helping Babies Breathe has been used. It'll have a similar look and feel, and will be customized per country. We've already had sort of the first runs of this go out and be piloted in Malawi and Bangladesh, where it is most welcome. So at the local level, there have been sort of two levels of accomplishments here. On the one hand, being part of this UN commission has been a platform to get 8 different Pathfinder countries, those are Senegal, Sierra Leone, DRC, Tanzania, Uganda, Malawi, Nigeria, and Ethiopia, interested in starting a push toward antenatal steroids, which was not necessarily in place beforehand. That means that not only are there policymakers and decision makers who are advocating for the use of this, but they are also allocating budget line items to procure these drugs and to fund the training and so on. So that's an exciting move. But then more specifically, in 5 countries, we've actually launched operations research that is designed to create these reference cases. So it would work very similarly to what we saw, or what I would imagine what is done in Ohio and in Illinois and in Utah and in any other continuous quality improvement process, where you would essentially map out what the steps are that the incoming mother goes through and figure out, well, what are the steps required for her to actually get dexamethasone, and where is that going awry? Why is the coverage rate right now at 5 or 10%, the way that Beth just described, instead of at the 80 or 90% that we see in the United States? So that's happening in 5 different countries. We are getting very encouraging results, and it's, in many cases, the first exposure to this continuous quality improvement methodology. So the hope is that once we get that started, you can then bring in all of the other maternal and newborn health interventions that would be augmenting outcomes across the board. So that's it. That's what we're doing. On to Eve.
I guess we'll do questions at the end. Okay. So in the context of this, in this meeting, what I thought might be useful is just to lay out a bit of sort of the geopolitical landscape around newborn health more broadly in global health. And so if there is an action agenda that emerges from this meeting, sort of where are the points of contact where we could build these initiatives into existing platforms globally. So basically where there has been renewed efforts focusing on newborn health on the global level. And where this is coming from is there was, back in 1990, the Millennium Summit that specifically focused on, there were a goal number 4, which was to reduce under 5 child mortality by 2/3. So there were, in the decade and a half, there have been amazing achievements in childhood mortality, but we really have not seen those same gains in newborn, neonatal mortality. So what we were left with then, because of these declines and other causes of child death, we're now finding 44% of all under 5 deaths worldwide are among newborns. And to quote Dr. Imes, that means that 2.6 million babies are dying every year worldwide. And as Beth was saying, 98, 99% of those newborn deaths are in low and middle income countries. So there is now increased awareness of the need to do something about those stagnant changes. And what's resulted as well is that preterm birth now has become the 2nd leading cause of all under 5 deaths. So things like malaria, diarrhea, pneumonia, all those things that traditionally we've made wonderful progress in those, but not so much in the period of newborn deaths, and particularly, of course, right around the time of that first day of life. So the timing of this meeting, actually, in the context of what's happening globally, couldn't have been better. So good job there, Russ. And so I actually, for the purpose of this talk, I actually put dates in, because just to give everybody a sense of timeliness and the opportunity that we're facing right now. So just last week and a half ago, the World Health Assembly ratified the language of the Newborn Action Plan. So this was an initiative led by WHO and UNICEF with a number of partners, Gates Foundation, AID, London School. I'm always leaving off agencies, which is really bad, but Save the Children was very prominent, as well as the Partnership for Maternal-Newborn Child Health. March of Dimes has been engaged. A number of global partners, national governments, NGOs, industries, including development of a number of materials, documents, toolkits, country, regional assessments and plans. How do we get these plans integrated into national efforts? And what accompanied this also is call for commitments from governments and partners to actually make this happen. And that will be the ongoing challenges if and how this goes forward. It's been, and here is, in fact, Melinda Gates, little Melinda Gates, in front of the giving a plenary on this topic specifically to the entire General Assembly. So you can get a sense of the high visibility and political will that's going on around this newborn initiative. So who we have here then is the Director General of WHO, Melinda Gates again. We have ministers of health from Zambia, Cambodia. We have the Assistant Administrator from USAID. Here's Liz Mason, who's head of maternal, newborn, child, and adolescent health at WHO. So you can get a sense of the level of people who are now bringing this to the forefront on the global agenda. This will require commitments from countries. Canada just stepped up May 29th, so last week now, for a $3.8 billion pledge for global MNCH. At the same time, May 20th, so this is all happening within the last 2 weeks, so Russ, good job. The Lancet series came out again on the Every Newborn, highlighting the initiative again, and a series of manuscripts that addressed all types of strategies, but clearly antenatal corticosteroids was an important component of that. One of the papers included country-level assessments of barriers and strategies of key elements of essential newborn care, and that include corticosteroids as one of those elements. So the other thing that's been going on is, in addition to these policy and program initiatives, are also a focus on the increased need for research in newborn health. That, as we've found from the other talks, we're woefully behind a number of other fields in understanding and the need for a comprehensive and coordinated approach to preterm research across the entire spectrum of research, from discovery, development, and delivery science. If we do have something that works, how do we scale it up? It was led, this initiative to develop what we called a solution pathway for preterm research was to develop a comprehensive research agenda by a lot of the lead research organizations. That research strategy was developed, which served as the basis for a new coalition that's being formed called the Global Coalition to Advance Preterm Birth Research. And this is a coalition of funding organizations so that we can advance visibility, coordination, and leverage additional resources for research in the field of preterm birth, and steroids being one component of that. So I'm just going to emphasize again a lot of these issues that have been pointed out already. So although we know we have a life-saving intervention, we will need to figure out how to integrate that and implement that safely in the context of low-income settings, where most women often, depending on the country, again, there tend to be low rate of facility deliveries. Women come into antenatal visits very late. They don't know their gestational age. That's very inaccurate. As we're saying, even in the setting of research and clinical trials, people use birth weight as a surrogate for gestational age. So in that construct then, where we also have rudimentary health systems, and as we heard everything already with the challenges around essential drugs, trained staff, staffing shortages, extreme poverty, there are human rights elements here that are very important that haven't been discussed, but are very important. And serious comorbid events, these tend to not be healthy women. They're living in situations of extreme poverty. They don't have good nutrition. They have high rates of bacterial vaginosis, of malaria, HIV, and regular bacterial and viral infections, as well as chronic diseases that are not detected or managed, such as diabetes, gestational diabetes, just not found. There's not even cervical screening for cancer and that type of thing. So within this context, how do we do this safely and effectively? And with the knowledge that one size does not fit all, dealing with a Muslim woman in Afghanistan who has to cross on a donkey over a mountain is not the same as a woman in Buenos Aires. So to conclude, this is a very exciting time. It's an exciting time to have this meeting in the context of what's happening globally. I think we do have an opportunity for action. I think this initiative, even though I think it's really exciting to see a focus on one intervention per se, but at the same time, unlike some global strategies, vaccines, where you can implement it in a vertical way, I don't, because I have the pulpit now and I get to say what I think. I personally do not believe this would be a good way to move. I don't think that steroids would be a good intervention to move forward in a vertical fashion. We don't have functional systems for pregnant women and newborns. Women are also dying at very high rates because they're not getting to facilities to deliver. So I think we should use this as a strategy to harness efforts together and try to advance the systems of maternal child health delivery. So all these areas that we've talked about to be dealt with collectively. I also think this issue of operations research, implementation science, and in particular program evaluation will be critical to build in at the forefront. There are not systems. We don't have birth certificates. They're not only like not good birth certificates, like we heard yesterday, there are not birth certificates. There's not vital registration systems. Medical records, even in hospitals, are rudimentary and often usually can't be collected in any kind of systematic way. So we will have to build up systems to know if there are adverse effects of what we're doing. You will not find it unless you build it. So I think the challenge then to us is how to move forward and how do we build the advocacy and commitments to actually reach the tipping point. I think we're at a unique time to do that and look forward to the discussion. Thank you.
Okay, so I want to pick up on where Eve left off, mostly by introducing what I think is a very large note of caution to the implementation of corticosteroid treatment in low-income countries. Just to make the point, Beth started out that there were 21 randomized clinical trials of corticosteroids in developed countries. There are 0 studies that I'm aware in developing countries. And the study that Beth described, the data will be available soon. We'll have a sense of whether it was effective or not. But at least for now, what I want to point out is that there is no data either describing effectiveness or safety of antenatal corticosteroids in any low-income country, and that I'm aware of. It may be that some of you might be, but there's no data to show safety or efficacy. So that's the bottom line of what I want to talk about. To start with, every high-income country randomized trial of antenatal corticosteroids has been conducted in hospitals with what I believe to be good neonatal intensive care available. So what we're studying is not just corticosteroids. We are studying corticosteroids, or we have studied corticosteroids implemented in a place where there's very good other kinds of care available. That is not the case in most low-income countries. So as far as I'm aware, there's no evidence that antenatal corticosteroids improve neonatal outcomes in the absence of newborn intensive care. There is also no evidence that antenatal corticosteroid use is safe for the mother or newborn in areas such as sub-Saharan Africa or Southeast Asia, where, for the most part, sterile delivery, sterile newborn care is not routinely practiced, where there are, as Eve pointed out, high bacterial load, all kinds of chronic infections are common, and many mothers are malnourished. These are different populations than where corticosteroids have been studied in especially the US. Delivering antenatal corticosteroids to the right population in terms of gestational age, and we've heard about all the issues in the US or in high-income countries. You can imagine what it's like where there's no ultrasound, where the women can't use calendars or have no sense of when their last menstrual period is. So delivering antenatal corticosteroids to the right population in terms of gestational age is problematic in areas without ultrasound dating and where LMP dates are often unreliable. We talked about, I was impressed with Dr. Hedriana's talk about the toolkits and how difficult it is to figure out who's high risk and who's not high risk and who to give steroids to and who not to. Delivering antenatal corticosteroids to women at high risk for preterm birth without having highly trained birth attendants, for me, is also problematic. Knowing who is at high risk for preterm birth, I think, requires considerable training, and I think it's going to be very hard to take even many of the physicians in the countries where we work to get them a sense of who should be eligible and who shouldn't be. And just remember, half the world's babies are delivered at home by a traditional birth attendant. We've done, in the global network, a fair amount of studies on traditional birth attendants. More than half can't read. Most are innumerate. They can't use calendars. They don't have watches. And to take that level of person who's delivering half the babies and to try to get them up to speed to use corticosteroids appropriately, to figure out who's preterm and so forth, is a huge, huge challenge that is going to be very, very hard to overcome. And for these reasons, we've heard about overtreatment in the States, where there's well-trained people with ultrasounds and everything else. I believe there's a possibility that massive overtreatment is highly likely, but it may be that what the trial will show is that there's huge amounts of undertreatment as well. So hitting the sweet spot, it's hard to do in New York or California. Imagine in a community in Zambia or in Pakistan. It's going to be very, very much harder. The study that Beth described is different from nearly all prior trials of antenatal corticosteroids in that it's not individually randomized, but cluster randomized. And so what this trial to do, just to emphasize, is trying to understand the impact of corticosteroids in a community. So it's not of the women who come into a specific hospital. It's what's going on in the whole geographic area. It's trying to answer, can you increase use? And then if you do increase use, I wrote it here, it seeks to determine on a population basis whether antenatal corticosteroids can be increased, and if antenatal corticosteroids can be increased, is it increased in the right population? And that's a huge question, whether again, you can define the population appropriately to get corticosteroids. And if you get it right in the target population, the big question is, does it improve outcomes? And we don't know that for any developing country setting. And then because of all the infectious stuff I talked about, especially in low-income country settings, are corticosteroids safe for the mother and or the fetus or newborn? So my take on this, and let me start out by just to say, I've been a huge advocate for corticosteroids. I was on the consensus panel and all of that stuff. And I'm a true believer that in developed countries, corticosteroids are safe, effective, and should be used. And I think all the efforts that we're putting forward in the US are appropriate. And so I think that it is likely that antenatal corticosteroids used in well-equipped, low-income country hospitals with highly trained staff and with newborn intensive care will have results similar to hospitals in high-income countries. And so I think there's no data to show that, but I don't have any reason to believe that a high-end hospital in South Africa or Pakistan or India should have particularly different results than those that have been achieved in the trial. So I'm not saying that we shouldn't use corticosteroids in those specific locations. What I'm concerned about, and there may be a slide a little bit later, I'm concerned about most of the hospitals in developing countries that don't meet that definition. This study here was powered to determine the difference in outcomes with antenatal corticosteroid use across all participating sites and clusters. So it had a big sample size, but it needed that kind of power. Whether it will be able to discern differences in outcome with antenatal corticosteroid use in different types of facilities, I don't know if we'll learn that from this study. So it may be that another study that really needs to get done is in hospitals in developing countries. If you randomize them to corticosteroid use or not, you'll improve outcomes. We don't know that, but this study was a geographic-based attempt, and it didn't focus on home deliveries, or it didn't focus on clinic deliveries, or hospitals, or very good hospitals. And I don't know that you're going to get that data out of this study. For me, the major issue in low-income countries relate to efficacy and safety of corticosteroid use in home deliveries, in clinics with really no newborn care or rudimentary newborn care available, or at least in my experience, in the poorly staffed hospitals with little attention to sterility or little capability to provide newborn care. And I think that describes, for me, many of the hospitals in low-income countries. And these are also locations, again, where, again, the mothers are different than the mothers in the high-income country studies. They tend to be somewhere around a third of them are malnourished. They have a high burden of infectious disease. And their outcomes with antenatal corticosteroids may be very different than those of healthy mothers delivering in a high-income country hospital. So I believe until there is data on safety and efficacy of antenatal corticosteroids in these locations, I believe that corticosteroids should not be used in those locations. I think we are making a mistake until there's data by rushing this thing out. And just to say that I'm not alone, this conclusion is in agreement with the published results of a conference on antenatal corticosteroid use in low-income countries convened in 2010 by USAID's MCHIP project, Save the Children, Newborn Intensive Care Unit, as well as a recent editorial published in Lancet Global Health by Azad and Costello. So there's at least some other groups that are thinking at least along the way that I've presented this. And from the 2010 article, I just took a couple of sentences. There is strong evidence regarding the effectiveness of prenatal corticosteroid use in hospitals in high and some middle-income countries, usually in settings with high-level newborn care. For births occurring in hospitals in low-income countries without high-level neonatal care, or births outside the hospital, no studies have been conducted to evaluate prenatal corticosteroid use. The efficacy and safety of prenatal corticosteroid use in these settings must be evaluated. And another couple of sentences. The conference working group recommended expanding the use of prenatal corticosteroids in hospitals with high-level newborn care in low-income countries. They were taking a leap of faith but the conference at least felt that that was a reasonable leap of faith to make. For other low-income country settings, further research regarding efficacy and safety should precede the widespread introduction of prenatal corticosteroids. And then I'm going to throw in just my last two slides. These are personal feelings about obstetrics in general, but the history of obstetrics is rife with well-meant introductions of poorly evaluated interventions aimed at improving some pregnancy outcome, which when tested after widespread use have proven ineffective or even harmful. And my hope is that antenatal corticosteroids in low-income settings won't be one of those interventions that where later on we find that there was no impact or damage. And this is a slide I used to use a lot, and I had to go back 10 or 15 years to find. But this is at least one view of the history of obstetrics, which is a focus on a risk factor or outcome, identification of some intervention that seems to address that problem, but widespread use before there was appropriate study. And then ultimately, clinical trials or field studies to assess its effectiveness. You get disappointing results at that point, and then you move on to something else. And what I hope doesn't happen is that there's this widespread introduction of antenatal corticosteroids in places where it hasn't proved to be effective or safe. So I'll stop there.
From Illinois Collaborative. I just want to ask you design. It seems that you chose many countries to do this, and you said efficacy and safety, but safety issue is, to me, is a major concern, particularly dealing with different populations and, as you said, chronic diseases, infections, etc. And did you, the panel committee, thought of selecting one or two countries and examine the safety part first?
Yeah, I was going to say we had a lot of discussion about the safety, and we actually took over 2 years to go through the WHO ethics committee with this trial, which was, so WHO was one of our sponsors, but ultimately they've felt like it, based on previous evidence, it was okay to proceed. And one of the goals of the trial was to get sort of generalizability of results across many different settings. So, but you're right, we did think about that a lot and had many hours of discussion.
Yeah. And Beth, just to, can you all hear me? Yeah. The global network is an NICHD created network. It now has 7 U.S. sites paired with a site overseas. They chose, in their wisdom, the 7 sites, and so it's not that we as the group were particularly choosing specific countries. This, you know, you go to war with the army you have, and to quote somebody, that's what we had.
There's sort of, I think, a public health version of this same slide, and it has to do with the safety issue. A lot of times clinical trials are not really powered to identify adverse events because they tend to be more rare. And it's when you roll a public health effort into a population level that you detect to sufficient size the risk that you're causing to a population. So, I mean, I've personally had arguments with my pediatrician who wasn't allowed to give my kids the chickenpox vaccine, for a year and a half until after the vaccine came out, because I know the pattern of public health interventions. So once we take an intervention and move it to population level, we really have to have the systems in place to measure events, because trials are not often powered to detect that.
Yeah, and actually, he was exactly right. So this trial was powered on the 28-day neonatal mortality, and the safety was the secondary. But you're right, we weren't powered to look at that specifically. Sorry.
Well, that's a wonderful segue into my comment that Beth mentioned. in passing, that something that hasn't been mentioned before is registries and the power of exploiting registries. And with patient registries, you can follow a group of patients within your own practice or your own hospital or your own self as an individual clinician, or within countries. And it's a great way to get follow-up data. And a lot of hospitals, when they're purchasing the electronic health records, do not purchase the registry's modules. And I honestly don't know how much they cost, but they're really valuable for research and for quality improvement. And if you're interested, also ARC has done a lot of work in developing patient registries, and the new user guide just came out. And then one final comment in terms of quality improvement is that if we all think, building on Bob's statement, if we think it's hard to get clinicians to implement an intervention, it's even harder by a magnitude, I don't know of what else, to get them to stop doing it.
Yeah.
So we need to think carefully before we start something.
That's a good point.
Thank you very much, all four of you. My question has to do also about sort of innovation in middle-income countries. And what I mean by that is, Mary Campbell Bliss gave an example earlier today about how there's a problem with the transfers in the United States, largely. There's no checklist that goes along. And in the United States, I'll exaggerate the example a little bit and say, well, we think immediately, well, let's do it electronically and have some sort of record to go along, when in fact quality systems have been around for a very long time, and there are good examples where low-tech interventions have worked and really made good quality improvements. So I don't know if you have any examples that you'd like to share now sort of in this area, but if the group could think about those kind of things, and because they can be issues for communities here and, of course, around the world.
Yeah, and I was just going to add that is part of the reason we did that little corticosteroid box, because a lot of women may receive their first injection at a community level, and then they could take the box with them that would have the date it was administered and how many doses was given, so that if she did make it to the hospital, then the hospital provider would have that information. But you're right, it's very good idea to be thinking about, and you need some of those low-cost, easy items. Sorry.
Yeah, Dr. McClure, that is very interesting study that you are working with as a team. It's a great effort, and I think this is one of the things that, as it is not yet done any before, apart in the lower income country, that's important. We're looking forward for the results. I would like to ask you about specifically for those other categories that are known, not the doctors or the nurses, the other group at the community. That's what their role on that part is related to service provision, providing some of the service, or delivering the health messages only, and doing the referral and all of this other stuff. And you are expecting another thing. Are you expecting for the outcome to reduce the neonatal mortality by 30%, as mentioned?
That was ambitious. Yeah. No, and that's a good question. So beyond nurses and midwives, many of the countries, I think Joel was alluding to this, had regulations about who can give injections. So the traditional birth attendants or community health workers, a lot of their role was the notification and helping educate communities about signs of preterm birth and when to seek care. And then we had sort of cell-based systems where they would have a nurse midwife who was authorized to give the injection on call, who could come assess the mom and give the injection. I don't know if that, yeah. But we do, because as someone was saying, the variety of our countries, we had very different systems that had to be adapted sort of locally to each country. Sorry, Winnie.
Winnie Webasa would Save the Children. I don't know whether what I'm saying is a comment, a statement, or just to add to some of the issues that are being discussed here. But just to understand the challenges in the settings where we work at. So Save the Children we try to implement programs. We are part of the MCHIP program that was mentioned. We are doing a lot of work at the global level, but we also try to get these interventions into practice and look at the challenges. So we're talking about having care at the district hospital. When we think of district hospitals, they're not the district hospitals we have here. The district hospitals in the settings where we're working, if you're thinking of Uganda, Malawi, maybe even very different from Mali, Guinea, the Francophone world. You may have a district hospital, there's not a single specialist, there's no obstetrician. So when we're talking about physicians, we're talking about people who are minimally trained and are not operating at the specialist level. And we are trying to get them to provide interventions and make these decisions with women in the conditions that we're talking about. But the district hospital is obviously the level where we may have the best level of care, where we have at least some physicians with some level of training, some support, some of the interventions in place, and a system that may be working. The biggest challenge is most of the women do not deliver at that level. Most of the women are delivering at health centers and below. And we're doing a better job of getting women into health centers. So it's not that all of them are still delivering at home. But then how do you get the women who need antenatal steroids into district hospitals in a timely manner so that they can get them at the right time? That's our biggest challenge. And that's what we have to come, we and the women, I think the high income hospitals that Bob was referring to, those are hospitals in cities. And the women who are delivering there are wealthy, educated women who are getting private level care. The malnourished women, the teenage mothers, the mothers with no level of education are delivering in health centers and below. So how do we move those two pieces? Yeah. That's what we need help with.
Well, just wanted to say I agree with everything she was saying, and really illustrates how hard it's going to be to do this, and to take people, at many of the district level hospitals that I've seen, there's really nobody there that has the expertise to make these kinds of decisions that we've been talking about. The other point I just wanted to make, just to come back to the research that's necessary to do this right. There are estimates that 90% of the research is focused on 10% of the world's problems, and almost no research has been focused on this issue in low-income countries. And this is a huge question, whether it's corticosteroids or any other intervention. We have no idea really whether they work or don't work, or how they'll work, or the best ways to implement them in many of these low-income settings that we've been talking about.
I just wanted to comment. We've had some really interesting out-of-the-box thinking, and also in developing countries, a lot of work, speaking just to the last person who spoke, about mobile health, technologies. There is a lot of other work going on in which the same issues we're struggling here and there. Can we develop a protocol for proper use? And it may be the protocol is to get people into specialized hospitals. I know I have a colleague who's doing work in Zambia trying to help move people from home births when there are problems early, and sort of trying to think about technologies that sort of ACT is, as I correctly appreciated many people's comments, is not it's probably a terrible vertical activity in an international setting, but it is part of a system of care, and we do have to think about it at all levels. And so while I applaud your decision to start at the district level hospitals, I think that had much merit, but the issues are really how we're also going to get those same things, because your caution, Robert, on this is, we're not going to do this so quickly, and you probably are right in your caution. But I also think we have to think about mobile technologies and other things that allow bringing some of that down to the local level. And this first step might not be, do you give antenatal corticoid steroids, although that may end up being your over-treatment is how it's probably going to happen, but it may be the referral in as the sort of key next step. So I just wanted to say that. I had one other last comment, which is totally different, which is, Eve, you actually mentioned human rights, and it came up only one other time in this entire conference, sort of thinking about, we were having a discussion yesterday on should you inform, how do you make things. There is a human rights element to this conversation. if we're really thinking about the number of women and babies that are dying in developing countries. And, you know, we have to balance both our science, which is what we're being cautioned right here, with our human rights commitments to achieving optimal health for everybody. And I don't know where that balance is, but as we think broadly in this conference, we do have to think about this from a lot of different perspectives. And I just wanted to say, and I wondered if you had any comment on the human rights element. It was a line in there, but or either of my two comments.
Yeah, at least I'll start. I feel very strongly that the human right is to have be taken care of with evidence-based care, and not to throw stuff at people just because somebody believes it's useful. So I think the human right element here is for us as a community or a world to study these issues in an appropriate way so we can give appropriate treatment, not to throw stuff that we think is beneficial.
I think in the context of my slide, I actually meant that women don't have rights in countries, and that in itself is a huge barrier to access. So, for example, in Afghanistan, women cannot travel unaccompanied without a man. And the distances and all that, women are viewed as property. It's often the mother-in-law who's determining what care a woman should and shouldn't get, if she should go to hospital or not. You're fine, stay here. So that was sort of the intent of that. The other issue is I don't have data, so am I allowed to talk about human rights without data? I think so.
I don't have any data. I wasn't raising data. I was just trying to broaden our conversation.
So, we have a disparities issue, and personally, I believe that one of the reasons we're seeing extreme disparities in the health of women and newborns is because, in general, they're an underpowered population globally, here as well as overseas, and even more extremely overseas. So I don't think we've seen the same amount. Oh, in fact, that was raised this morning, wasn't it? It's like newborns it's not of interest to the general population, right? So it's the same issue that there may be people in a sector who don't count as much. And I think that we have challenges in the field of obstetrics and newborn care because of that. So I think we have a number of equity issues that have to be addressed in this context. And getting the funds for research is as important of element as any.
Let me chime in on that as well. I definitely agree with Robert's position that we need more research in order to understand how these therapies really behave in the developing world context. At the same time, I think there's a question of how are we going to get started on actually saving lives? This is an intervention that's been around for 40 years. It is the logo of the Cochrane collaboration in terms of evidence-based medicine. That little circle with the stuff, that's antenatal steroids. So here we are saying that no, we need to slow down, wait for more studies. I think there's a balance to be had there in order to make sure that we actually see change in our lifetimes. So on the one hand, we've got the efficacy studies in the high-income countries that Robert points out. Yes, it's very strong. We also have some efficacy data from middle-income countries where we've seen that the mortality effect is actually higher in the middle-income countries than in the high-income countries. And that's because many of these kids are actually bypassing a need for mechanical ventilation or CPAP or other interventions that weren't actually present. So it is conceivable to consider that mortality effects could be better than expected, not worse than expected. I'm not saying that we should go out willy-nilly and throw it at everybody. That's not what I'm saying at all. But we also should be open-minded to the notion that there is a time to get started with this work. From a safety point of view as well, yes, there are concerns about infection. But when we look at the Cochrane Review and where we've seen placebo-controlled trials of dexamethasone, and we look at the infection rates, the data is quite spread out. The data set is very small, and it gives me pause that if it were my baby, what would I want to do? And then when we think about doing trials going forward, how are you going to come to an IRB and say that you want a placebo randomized controlled trial for something that's been around for 40 years and has more mortality endpoint data than basically anything else we do in the perinatal world? So there's a balance. Yes, we need caution. Yes, we need more research. I agree with that. But no, we should not come to a grinding halt because we're concerned.
Well, thank you Let's thank our speakers.